So we're going to talk about spirometry, and then we'll do a little measurement.
Spirometry is a common test for lung function. It is used to diagnose asthma, COPD, pulmonary fibrosis, and other lung diseases. It can also be a helpful tool to monitor disease progression and evaluate effectiveness of a treatment plan. A tube-like device called a spirometer is used to capture and record air volumes and breathing speed. A spirometry test typically reports 4 respiratory volumes: tidal volume, TV, the amount of air inhaled or exhaled during normal, quiet breathing without effort; inspiratory reserve volume, IRV, the amount of air that can be inhaled with maximum effort after a quiet inhalation; expiratory reserve volume, ERV, the amount of air that can be exhaled with maximum effort after a quiet exhalation; residual volume, RV, the amount of air remaining in the lungs after a maximum exhalation. These volumes are used to calculate other parameters called respiratory capacities. Inspiratory capacity, IC, the maximum amount of air that can be inhaled after a quiet exhalation; functional residual capacity, FRC, the amount of air remaining in the lungs after a quiet exhalation; total lung capacity, TLC, and vital capacity, VC, the amount of air that can be exhaled with maximum effort after a maximum inhalation. This is basically the volume of the deepest breath the lungs can possibly handle, and is an important indicator of pulmonary function, as well as strength of respiratory muscles. Vital capacity can be measured as slow vital capacity during slow, relaxed breathing, or as forced vital capacity, FVC, when the patient is asked to breathe out as hard and fast as possible. While there is little or no difference between these two values in healthy individuals, people with difficulty exhaling usually show significantly lower FVC. Another important parameter obtained during forced spirometry is the forced expiratory volume, FEV1, the amount of air that is exhaled during the first second of forceful exhalation after a full inhalation. FEV1 is used to calculate the percentage of air that is expelled during the first second. This FEV1 over FVC ratio inversely reflects the resistance to expiratory airflow. In healthy people, it is around 70 to 85%. A smaller number means increased lung resistance. Spirometry is useful in differentiating between restrictive and obstructive pulmonary diseases. Restrictive lung diseases can be inspiratory or expiratory. Inspiratory restrictive are conditions in which lung compliance is reduced, limiting lung expansion when inhaling. This can happen either because the lungs become stiff as a result of scarring or fibrosis within lung tissues, or the respiratory muscles are too weak to inflate the lungs. Expiratory restrictive is when exhalation volume is limited due to weakness of accessory muscles involved in deep exhalation. Restrictive lung diseases are associated with decreased lung volumes, or total lung capacity, TLC. Obstructive lung diseases, such as asthma or COPD, on the other hand, show a normal or somewhat increased total lung capacity, TLC. This is because the obstruction increases lung resistance, making breathing out harder and slower, and this results in increased residual lung volume. Vital capacity remains normal during quiet breathing, but when breathing rapidly, a higher pressure is required to overcome the increased resistance, and forced vital capacity is reduced. A more reliable indicator of obstructive lung disease, however, is the lower percentage of air that is exhaled during the first second of forceful exhalation.
All right, so a spirometer is the machine that measures respiratory volumes, and so that process is called spirometry. The factors that are going to affect lung volumes are the age of the patient, the sex, and this really is more attached to size. Clearly, if somebody has a larger thoracic cavity, they're going to have bigger lungs inside them. And so it's not just height, although we're about to look at some charts where it's going to be height involved. But kind of think about it, someone with bigger lungs is going to have bigger volumes than someone that has a very small frame and has very small lungs. Okay, so that comes into play. And then physical conditioning, this has to do with just the muscles. If somebody does aerobic work or exercise, then they're going to have stronger respiratory muscles. Okay, so they'll be better conditioned. When we get to disease, we're going to split up our diseases. Typically, they're either obstructive diseases or they're restricted diseases when we talk about the respiratory system. And so disease also comes into play with respiratory volumes. And remember, compliance, that has to do with the stretchiness or distendability, okay, ease of stretch of the lung tissue, but then also the thoracic wall itself. So some structural things to do with the skeletal system and the muscular system. Then airway resistance, this has to do with the airways. So remember, we learned all about the trachea and the bronchi and the bronchioles. So all of that is what I mean by airways. And airways can be very open, which has low resistance, or they can be blocked or constricted or collapsed, and then that would increase airway resistance. So all of these factors affect lung volumes. So your book just kind of talks about pulmonary function test, spirometry. The instrument is a spirometer. And we're going to kind of just key in on forced vital capacity, forced expiratory volume. We'll talk about residual volume and total lung capacity. The last part we talk about balance, we will be doing some ABGs, which are arterial blood gases. And so I'll connect those later in this unit. All right, so we talk about in spirometry, and I think I'm just going to do it with this picture. So spirometry measures volumes, and then you can add up volumes to calculate capacities, okay? So the things that are measured, so if you were to just completely relax, like, mouth open, and just let your diaphragm, your external intercostals, all of them just relax, you would be right here as far as your lung volumes. So this is measuring the volume of air inside the airways in a lung, and it's doing it in milliliters. Okay, so if you just sort of relax, you would be down here. Then if you took a normal breath in, okay, this would be calculating the amount of air inside your lungs, and then a normal breath out. So a respiratory cycle is an inspiration and an expiration. When you're sitting there like on a boring day, it's called tidal volume. So just think about the tides of the ocean. The tides go in, and the tides go out. The tides go in, the tides go out. And this is going to be about 500 mils or half a liter for males and females. But if you take like a normal breath in, you have more, right? If I told you to go run, you're going to have to take a really big breath in. So what you have on top of your tidal volume, they call this right here in this peach, the inspiratory reserve volume. And so when you take your biggest breath in, you're at the top right here of your inspiration. And so this part above your tidal volume in would be an inspiratory reserve volume. So big breath in, normal breath out, tidal volume. But then if it's your birthday and I put some birthday candles in front of you and say blue, you know that you can blow out some as well. So that's your expiratory reserve volume. There's also this down here in the purple, and notice there's nothing to measure down there with a type of spirometer that we're going to use in most types of spirometers. It's called residual volume. Our airways are open, okay? So you've got your trachea, which is held open by cartilaginous rings. You've got your bronchi, some of them have cartilage. But then if your lungs are inflated, your airways are open, okay? And no matter how much you breathe out, till you're absolutely red, you cannot force all that air out. We'd have to remove your lungs, roll them over with like a steamroller or something to get all the air out. And so this is called the residual volume. Okay, so even with the biggest exhale, you still have air inside your lungs. So infants, when they are born, right, so they take their first breath, that inflates their lungs. They can tell the difference between a stillborn child and a child that took a breath, okay, based on are their airways open or not. Not to get morbid, but I'm just saying, like, once you breathe, your airways are open. Okay, so there's some volume there. What's that?
I think a lot of this class is morbid.
Yeah, well. Okay, so once there are volumes measured, then you can calculate capacities. Okay, and we just watched the video. So if you take inspiratory reserve volume plus tidal volume, you have inspiratory capacity. And if you take expiratory reserve volume and residual volume, you have functional residual capacity. Vital capacity, so vital means for life, right, is the amount of air that a person has control over, okay, that a person can move. And so we're going to measure this. You're going to take your biggest breath in and then blow out so you can't blow anymore. And that's the amount of air somebody has control over to move, so vital capacity. Total lung capacity is all of the volumes. Forced vital capacity, like I said, is really when you blow forcefully, you're measuring your forced vital capacity, so all the air you can move. And what is relevant to medicine in tracking respiratory disease is what's called FEV1. How much of that forced vital capacity comes out in the very first second. Okay, and that can be very telling. It's going to be the ratio of FEV1, so forced expiratory volume, because you're blowing out in 1 second, over the vital capacity. And so this, normally it's going to be 70 to 85% in most people. That first second, the majority of air is going to come out. Okay, if somebody has obstructive disease, this is going to be lowered. Okay, and as they progress in disease, this is going to get lower and lower and lower. So we can distinguish between obstructive and restrictive diseases, and also track a patient's progression through their disease. Okay, or treatment. We can be positive about it. Okay, but we know all respiratory diseases are going to reduce vital capacity. Like I said, that amount of air someone can move. All right, so they generalize it between obstructive disorders. Here's the take home. Obstructive disorders, we are talking about airways. So there's increased airway resistance. This could be because they're constricted, they're blocked, or they're collapsed. Like I said, we can tell, and typically people with airway resistance have a hard time exhaling. Okay, so that volume is going to go down, and so their ratios are going to go down, and we're going to do some problems. Restrictive disorders, think of a stiff balloon, okay, or think of a rib cage with a really tight belt around it. Okay, it's going to be difficult to inspire, and this has to do with not the airways. It's not an airway issue. It's a lung issue or a structural issue. And so usually in this case, you see a normal expiratory, so forced expiratory volume 1, FEV1, and then if you take the ratio, because vital capacity will go down as their disease progresses, so it may even be higher, so higher than 70%. Yep, all respiratory diseases. All right, so we're going to do obstructive pulmonary disease first. And like I said, this is going to have to do with the airways. So asthma is the most common, and we're going to look at it a little more closely. They can either have hyperreactive airways, or they have just could be an irritant. Some people are triggered by exercise, and so we're going to get a constriction, right? And like I said, that's the most common. We're going to talk about COPD in detail, and then there's also cystic fibrosis, which also affects airways. So we're going to kind of talk about those. All right. So what happens in asthma? So here's a normal airway, and like I said, the bronchioles can either constrict or dilate based on body's needs, so that's going to control ventilation. In an asthmatic airway, typically it's chronic inflammation of the airways, and so the walls get thick. Okay, they get thick and they get inflamed, and then if they have an asthma attack, then there's also that bronchial constriction. Okay, so it gets very difficult to breathe during an asthma attack. Usually, an asthmatic is going to be prescribed an inhaler, which will be a drug that's going to dilate those airways. Okay, and yep, this is what I do to my kid. So my daughter has asthma, and she, I was doing this, and so she did her forced vital capacity. Like I said, she's very petite, and then she used her inhaler, and so she went up 300 milliliters of air. She was not having an asthma attack at the time, but she just wanted to do it, see what her inhaler did for her. So that's the kind of fun we have around our house. All right, so asthma is #1 pulmonary disorder, very common. COPD, so chronic obstructive pulmonary disorder, is a combination of emphysema and bronchitis. Okay, and then some people will be more emphysema oriented and some people may have more bronchitis to them, okay, but it's usually both of them together. And usually it is someone that smokes, but not always, okay? They may have worked in an environment where or lived in a city with a lot of air pollution. And then there is a genetic predisposition, which also can influence whether somebody develops COPD. So we'll go on the bronchitis slide, because bronchitis can also be caused by infectious diseases as well, but just continual irritation or inflammation. And so what happens, the airways are going to start making a lot of mucus. And so typically a calling card of bronchitis is just a wet, chronic cough. Okay, that has to do with the airways are getting blocked by mucus. Emphysema is a little bit different. Emphysema, we're going to get a combination of things, but one of the things is the breakdown of the elastic surrounding the air sacs. And so what you end up with is we're going to lose our alveolar walls, and then you also get collapse of airways. And so you get collapse of airways, and we're going to get air trapping, and I'm going to show you a picture in a second. But what happens if someone has COPD, obviously they're going to have dyspnea, so they're going to have labored breathings, particularly when they're exerting themselves, okay, because they cannot meet that oxygen demand. And two, because they have this overproduction of mucus and this chronic cough, and it isn't always cleared, they'll also be subject to frequent infections. And usually they smoke too, so they don't have their cilia and other problems. So hypoventilation, so not enough air is reaching the respiratory membrane. Hypoxemia, so low oxygen in the blood, which can lead to respiratory acidosis. So this is just looking at normal lung tissue up here, and so you see each one of these little air sacs is an alveolus, and what happens in emphysema, and particularly they lose their alveolar wall. So notice you have these big, huge open spaces, and then you get a collapsing of airways, and so you end up with air trapping. Okay, this is not usable air, okay, because this is not an exchange, but you can see it's just trapped inside the lung. Okay, because of airway collapse. So we lose alveolar walls, which that's the site of external respiration, and you get air trapping. Yeah, so the air just stays in there, and that's what it looks like in a lung. Another type of obstructive disorder is cystic fibrosis, which is a genetic disorder, and the mucus is very thick and doesn't move. Okay, so it doesn't flow. The cilia are supposed to be able to roll it up. It's just too thick. And so that too can block airways, and people with cystic fibrosis get frequent respiratory infections. All right, so those all had to do with increased airway resistance. Restrictive pulmonary disorders have to do with the compliance of the lung or the thoracic wall. So think of, like I said, a balloon that's really hard to blow up. So, did you have a question?
I don't understand the difference between chronic bronchitis and cystic fibrosis.
So cystic fibrosis is a genetic disease.
Okay.
Yes. Good question. So pulmonary fibrosis is a cause of the restrictive diseases, and in pulmonary fibrosis, the tissue surrounding the airways gets very thick, and so becomes non-compliant. And so it's difficult for the patient to take a breath. Also, because the respiratory membrane can thicken, you do not get that gas exchange and external respiration. It doesn't work as well. You can also have thoracic non-compliance, so chest wall deformities, kyphosis, or obesity, that excess weight. So when someone's trying to take a big breath, it's just harder to do. And anytime that there is fluid in the lungs, that too, you're gonna get hampered gas exchange, but also it's gonna affect the respiratory volumes, because that's gonna affect the elasticity of the lung tissue. And then tuberculosis is a bacterial disease that too will decrease compliance, or that stretchiness, right, of the lung to go wherever the thoracic wall goes. So, okay, so we have a couple case studies for you. And like I said, we're going to be calculating that ratio between forced expiratory volume in the first second, so FEV1, and that vital capacity. And then, like I said, over here on this particular picture, it could be for restrictive, it could be skeletal system disorders, it could be muscular system disorders, and like I said, we talked about pulmonary fibrosis, and then we talked about obstructive disorders up here. And I like to put these pictures in because we have kind of talked about a lot of these things, and we were talking about cardiac problems before, so it all plugs in together.